Now we call upon Dr. Venipriya Sigamani to present on 8.5 syndrome. The only ocular movement is the same as angle of mouth.
Good morning, everyone. I'm going to present a case of 8.5 syndrome. The only ocular movement is the same as the angle of mouth. It is a rare pontine neuro-ophthalmologic syndrome. Consists of ipsilateral conjugate horizontal gaze palsy, ipsilateral internuclear ophthalmoplegia, and ipsilateral lower motor neuron facial palsy due to the involvement of medial longitudinal fasciculus, pontine paramedian reticular formation, and seventh nerve fascicle. Our case is a 72-year-old male with the complaints of incomplete closure of right eye for the past 3 days. This was his presenting symptom, and complaints of drooping of mouth on the right side for the past 3 days. No complaints of double vision or blurring of vision, no other significant neurological or ocular symptoms. He was a newly diagnosed DM. On examination, general examination was no abnormality detected, and systemic examination was normal. CNS higher mental functions were intact. On ocular examination, head posture, there was a mild head turn to right side. Primary position, the right eye showed 15 degree esotropia, left eye 5 to 10 degree exo. There was a lag of thalmus of 2 millimeter in right eye with the loss of forehead wrinkling in the right side, loss of nasolabial folds on the right side, and drooping of angle of the mouth on the right side. There was no chin lift. This was the video showing the extraocular movements. So you can see the left eye abducting nystagmus with the right eye -2 adduction deficit, and supraadduction was normal, infraadduction was normal, and right gaze there was no movement. And only movement available was the left eye abducting nystagmus. So this was his extraocular movements. On the right eye, the visual acuity was 612 with pinhole improved to 6.9. Left eye, it was 636 improvement due to immature cataract. Pupil, there was no RAPD, both eyes. And length, right eye, pseudophakia, left eye, IMC. Fundus, it was normal. There was no evidence of edema or pallor in the both eyes. MRI showed an ill-defined T2 flare hyperintense areas in the right half of the dorsal pons in the region of the facial colliculus, suggestive of infarct. Since the patient had right horizontal gaze palsy with right internuclear ophthalmoplegia and right facial nerve palsy, and which is an element type, with the MRI showing right pons infarct, we came to the diagnosis of right 8.5 syndrome. 8.5 syndrome is a constellation of symptoms that occur due to the lesions involving the ipsilateral 6th nerve nucleus with fascicular portion of the 7th nerve and medial longitudinal fasciculus, resulting in a combination of ipsilateral horizontal gaze palsy and element type of facial nerve palsy and ipsilateral internuclear ophthalmoplegia. The most common causes are vascular lesions, demyelination, and rarely due to tumors. And prognosis depends on the etiology, and it usually has a good prognosis. Coming to the anatomical background behind this disease, the horizontal gaze center is situated in the pontine paramedian reticular formation, and is it situated in the, excuse me.
Your time is up, doctor. Actually, you can wind up with your discussion as well as conclusion.
Okay, ma'am. So 8.5 syndrome is due to the lesion of MLF, which showed the internuclear ophthalmoplegia, PPR of ipsilateral gaze palsy, and facial nerve fasciculus involvement, resulting in lag of thalmus and angle of mouth deviation. The only ocular movement available will be the contralateral abducting nystagmus with angle of the mouth movement. Conclusion, it is a rare pontine syndrome. A high degree of clinical suspicion should be there because usually present with the element type of facial nerve palsy, because it will be the most seeing component of the disease. A mandatory extraocular movement testing is a must in all patients with facial nerve palsy to pick up associated gaze palsies. These are my references. Thank you.
Thank you, doctor, for the nice case presentation. It was an interesting case. But I have one question for you. Was there any skew deviation?
No, ma'am. There was no skew deviation.
There was no skew deviation. What about the vertical saccades and pursuit?
No, ma'am. Saccades and pursuits were no.
Vertical saccades are usually present here when it is a horizontal. You will tend to have a vertical sometimes and nystagmus in these cases. Okay. Right.
Thank you, ma'am.